All right, let's dive right in. Welcome back to part 4 of our masterclass series on mastering sepsis. Today, we're setting the stage to completely demystify lactate. If you're a clinical documentation improvement specialist, a medical coder, or a revenue integrity auditor, you already know lactate is one of those biomarkers that just constantly pops up in charts. But, actually understanding what it means, how it behaves, and exactly why auditors scrutinize it, that's an absolute game changer for your daily workflow. So grab your notes, because we're going to decode the exact dynamics of this absolutely crucial biomarker. We've got a fantastic biomarker journey mapped out for this explainer. We'll cover the physiology of lactic acid, the etiology of elevated lactate, those critical diagnostic cutoffs, clinical triggers, and finally, the CDI and coding implications. So, Section 1, Physiology of Lactic Acid and Metabolic Mechanisms. We're starting with the baseline science here because, as a CDI professional, recognizing the severity of a patient's condition literally starts with understanding where this biomarker comes from. We just can't properly audit or code a disease process if we don't grasp the metabolic mechanics behind it, right? So, what exactly is lactic acid? Simply put, it's a completely natural byproduct of anaerobic glucose metabolism. Normally, our bodies use oxygen to break down glucose for energy, but when oxygen is scarce, a state we clinically call tissue hypoxia, our cells have to pivot. They switch to anaerobic metabolism just to keep the engine running, and the byproduct of that physiological backup system is lactic acid. It's exactly the same mechanism that makes your muscles burn during a heavy sprint. To put that into a concrete perspective, the human body naturally produces about 20 millimoles per kilogram of lactic acid every single day. So this isn't just some abnormal chemical that magically appears only when there's an infection. It's a baseline metabolic reality. Your tissues are continuously producing it, and your body is perfectly equipped to handle this baseline volume under normal, healthy conditions. While we're constantly producing lactic acid, we're also constantly clearing it. This standard clearance relies heavily on two main pathways, your liver and your kidneys. The liver primarily processes lactic acid through what's known as the Cori cycle, which basically converts it back into usable glucose. Meanwhile, the kidneys help eliminate the rest through routine urine excretion. Now keep this in the back of your mind, because it directly foreshadows how organ dysfunction, like liver failure or acute kidney injury, will eventually disrupt this entire delicate system. Moving into Section 2, Etiology of Elevated Lactate. This brings us perfectly to what actually happens when that physiological balance completely breaks down and lactate starts to dangerously pool in the bloodstream. What's really fascinating about this process is this sharp dichotomy. When you see elevated lactate in a medical record, it's generally due to one of two distinct mechanisms, or, sometimes a dangerous combination of both. On one hand, we've got excessive production. This is driven by tissue hypoxia, systemic hypoperfusion, where the blood just isn't circulating properly, or severe cellular and mitochondrial dysfunction. The cells are basically starved of oxygen, so they're churning out lactic acid in absolute panic mode. On the other hand, you have impaired clearance. Even if production is totally normal, if a patient has hepatic or renal dysfunction, the liver and kidneys simply can't clear the acid fast enough. And with sepsis? Well, you frequently see both of these happening simultaneously, which is exactly why those levels can absolutely skyrocket. All right, Section 3, Critical Diagnostic Cutoffs. So how high is too high? Let's introduce the exact diagnostic thresholds medical coders and CDI specialists need to look for in the chart, using the rule of numbers to really anchor our learning. Here are the crucial cutoffs you absolutely need to have memorized. A normal serum lactate level is going to be less than 2 millimoles per liter. Once we cross that line, a lactate level greater than 2 millimoles per liter is clinically defined as hyperlactatemia. But when that level surges past 4 millimoles per liter, we're suddenly looking at lactic acidosis, a dangerously acidic state that indicates severe metabolic distress and profound tissue hyperperfusion. These aren't just arbitrary numbers. They are the precise clinical boundaries between a stable patient, a sick patient, and a critical patient. Let's jump to Section 4, Clinical Management and Resuscitation Triggers. Let's see how all of this builds at the patient's bedside, exploring how these specific lab numbers actually trigger real-world aggressive medical interventions within standard sepsis protocols. As you'll see, clinical action escalates precisely with those diagnostic cutoffs we just talked about. Under guidelines like the Surviving Sepsis campaign, if a patient's initial lactate comes back greater than 2, it triggers immediate protocols, which requires the clinical team to remeasure it shortly after just to track the trend. But if the lactate hits 4 millimoles per liter or higher, it mandates aggressive, rapid crystalloid fluid administration, typically 30 milliliters per kilogram. So the physician's resuscitation efforts are directly tied to these lab results as they desperately try to restore perfusion and flush out that systemic acid buildup.
And finally, Section 5, CDI and coding implications. Let's bring it all home for our revenue cycle professionals. How exactly do we link these bedside clinical actions back to documentation requirements and CMS compliance?
The absolutely crucial point is right here in the CMS guidelines. Code assignment is strictly based on the provider's diagnostic statement. But, and this is a massive but, as CMS clearly states, clinical evidence should be present in the medical record to support that code assignment. You just cannot have a diagnostic statement of sepsis or septic shock floating around in a vacuum. It absolutely must be objectively backed up by clinical indicators. And lactate? Well, lactate is often the star witness.
Let's break down exactly why elevated lactate serves as irrefutable clinical evidence. Under the Sepsis 3 consensus criteria, validating a diagnosis of septic shock has very strict parameters. It requires the presence of persisting hypotension that actually needs IV vasopressors just to maintain a mean arterial pressure greater than 65. And, crucially here, it requires a serum lactate level strictly greater than 2 millimoles per liter, despite adequate fluid hydration. To put that into perspective, let's look at a quick scenario from our source material. Imagine a 65-year-old male with pneumonia and a lactate of 2.8. He's given fluids, placed on dopamine temporarily, but within an hour he's weaned off the vasopressor and his lactate drops to 1.6. If a provider documents septic shock in that scenario, the clinical indicators simply do not support it. The lactate cleared with hydration and the vasopressors weren't persistently required. This is exactly why lactate dynamics are a massive focal point for auditors during chart reviews.
So what does this all mean for you? If you're reviewing a chart that claims septic shock but the lactate levels are completely normal, or maybe they rapidly clear with just a little bit of saline, or, worst case, they were never even drawn in the first place, you have a major compliance risk. A provider's statement that a patient has a condition is sufficient to code, yes, but when the clinical indicators in the health record blatantly contradict or just fail to support that diagnosis, an immediate provider query or facility escalation is required for sure. It's literally your job to bridge the gap between those lab values and the clinical documentation.
Understanding these metabolic mechanics, the diagnostic cutoffs, and these compliance rules ensures that your coding is just as accurate as the clinical care provided. So the next time you see septic shock in a chart, ask yourself, does the lactate tell the same story? Stay tuned for Part 5, where we dive into the historical evolution of sepsis definitions, exploring the Sepsis 1 and Sepsis 2 consensus frameworks. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.